Imagine for a second, you're looking at a painting by Wassily Kandinsky.
Oh, yeah. Very chaotic.
Right. To the untrained eye, it's just this like chaotic explosion of abstract shapes, harsh angles, varying shades of
Actually,
gray.
a lot of noise.
Exactly. But what if your patient's life depended on you finding a tumor hidden inside all that abstract art?
Which is basically what radiologists have to do every single day.
It is. Translating those black and white shadows into actionable, life-saving clinical physiology. That's our mission for today. Welcome to a very special masterclass edition of the Deep Dive, especially for you medical students, young professionals, or just, intensely curious self-taught learners out there.
Yeah, we are getting deep into the hidden world of the gastrointestinal tract today.
We really are. And our source text is the Mayo Clinic Gastrointestinal Imaging Review from 2005, authored by Dr. C. Daniel Johnson and Dr. Grant B. Schmidt. And remarkably, they actually chose a Kandinsky-inspired abstract piece for the cover of their textbook to make this exact point.
I mean, it sets the tone perfectly for how clinical intuition is actually built. The authors understood that reading a CT scan or a radiograph, well, it isn't just spotting a lump.
Right. It's not just a Where's Waldo puzzle.
No, not at all. It requires this foundational matrix of anatomy and pathology to turn all that abstract data into a concrete diagnosis.
So to train that specific eye, they structured the book as an interactive atlas.
Yeah, exactly. They present you with the imaging findings and the clinical context first, but they deliberately hide the final diagnosis.
Oh, wow. So you have to figure it out yourself.
Right. You are forced to synthesize the visual data and commit to a differential diagnosis before you even read the solution.
Which makes it an absolute masterclass in active learning. So we are going to apply that same analytical approach today, working our way from the top down.
Starting with the stomach.
Yep, starting right at the stomach. Because the immediate challenge there isn't always finding the disease. Sometimes it's just, recognizing when the normal anatomy is completely playing tricks on us.
Which is such a massive hurdle. Distinguishing normal variants from true pathology is the absolute baseline of radiology.
If you don't master the normal stuff, you're basically chasing ghosts.
Exactly. You end up putting patients through completely unnecessary biopsies, which nobody wants.
Right. And the text highlights this notorious optical illusion in the stomach called pseudo-thickening. And to me, the mechanics of it remind me of trying to read the text printed on a dilated balloon.
Oh, that's a really good way to picture it.
Right. Because when the balloon is collapsed, the rubber's all bunched up, the writing is distorted and thick, and you can't actually evaluate the surface properly until you blow it up.
And if you don't blow up the stomach, so to speak, that bunched up normal tissue, particularly up near the esophagogastric junction in the gastric fundus, it looks incredibly suspicious.
It mimics a mass, right?
Yeah, on a scan, those collapsed mucosal folds can mimic a gastrointestinal stromal tumor or even gastric carcinoma.
Which is terrifying for the patient. So what's the fix?
Well, the mechanical fix is just adequate distension. You can administer effervescent granules to generate gas in there, or, simply use water or oral contrast.
But the positioning is really the key, right?
Right. The critical maneuver is patient positioning. Scanning the patient in a prone position or a right posterior oblique position.
And that just makes the gas move.
Exactly. It ensures that the gas naturally rises to the fundus, fully distending it. And if the mass suddenly disappears, well, it was merely an artifact of incomplete distension.
It's just a simple mechanical solution to a really stressful diagnostic problem.
Oh.
But gas in the stomach region isn't always just some helpful contrast agent.
Oh, definitely not.
Because there's a specific radiographic pattern where gas actually indicates a diffuse lethal emergency. Which brings us to emphysematous gastritis.
Yeah, and here we really have to differentiate luminal gas inside the stomach from intramural gas.
Intramural meaning inside the actual tissue.
Right. Emphysematous gastritis is characterized by gas within the stomach wall itself.
Which shouldn't be there.
No, not at all. This is driven by an invasion of the mucosal barrier by gas-forming organisms, commonly things like Escherichia coli or Clostridium perfringens.
Nasty bugs.
Extremely. Once they get inside the gastric wall, these bacteria rapidly multiply. So that gas you're seeing on the scan, it's the direct byproduct of their anaerobic metabolism.
So if you're looking at an abdominal plane film or a CT, and you see that trapped intramural gas, the clinical picture just totally shifts.
Completely. And the patient presentation correlates perfectly with the imaging. These individuals are profoundly toxic, severely
It's
ill.
a true systemic emergency.
Yes, with a very high mortality rate. You have to act fast.
Okay, so let's follow that idea of the stomach reflecting systemic issues.
Yeah.
Because once we know how to properly distend the stomach and spot, a diffuse intramural infection, the challenge kind of shifts to isolated masses and ulcers.
Right, the lumps and bumps.
Exactly. And there's this case in the source material that just completely reframes how I view gastric nodules. It describes a 1.5 centimeter round filling defect right in the gastric antrum.
The lower part of the stomach.
Right. And it has this central bilication like a little dimple. And the diagnosis is an ectopic or heterotopic pancreatic rest.
Meaning there is microscopic pancreatic tissue embedded and just growing directly within the wall of the stomach.
Which is wild. I mean, my initial thought looking at that is to panic about a dangerous neoplastic process. Like if it's growing in the wrong organ, shouldn't we immediately take it out?
It is a super common concern, but embryology actually explains it perfectly.
How so?
Well, during fetal development, as the gut tube rotates and the primitive pancreas is forming, small clusters of pancreatic cells can just sort of get left behind.
Oh, they just migrate into the stomach wall by accident.
Exactly. And autopsy studies cited in the text show these rests are found in up to 14% of the population.
Wait, 14%? That's incredibly common.
It really is. They are significantly more common than actual neoplasms, like gastrointestinal stromal tumors.
So it's mostly just an incidental finding.
It is, but here is the major clinical pearl. This tissue is still functionally pancreatic.
Oh, meaning it behaves like a pancreas.
Right. It retains its susceptibility to any disease that afflicts the native pancreas. So a patient can develop pancreatitis or pseudocyst formation or theoretically even pancreatic adenocarcinoma.
But isolated entirely within that tiny little rest in the stomach wall.
Exactly. It's fascinating.
That is fascinating. But that systemic interconnectivity gets even more dramatic when we look at Zollinger-Ellison syndrome.
Oh, yeah. Classic example.
Because the imaging for this shows a stomach that just looks devastated. You see these markedly thickened gastric walls, severely enlarged rugal folds, those thick ridges of the stomach lining, and just intractable peptic ulcer disease.
It looks like the stomach is the primary problem.
Right. But it's not, is it?
No, the stomach is merely the victim here. It's responding appropriately to a pathologic signal coming from somewhere else.
And what's driving that signal?
The engine driving Zollinger-Ellison syndrome is a gastrin-secreting islet cell neoplasm, usually located in the pancreas or the duodenum. And this tumor just floods the systemic circulation with the hormone gastrin.
And gastrin is that direct signal telling the stomach's parietal cells to pump out massive, just totally unregulated amounts of hydrochloric acid.
Exactly. The acid then completely overwhelms the mucosal defenses and literally chews through the stomach lining.
So the radiologist looking at those thickened gastric folds basically has to trace that physiological pathway backward all the way to the pancreas.
Right. You're looking at the stomach but diagnosing the pancreas.
Yeah.
And the text highlights the malignant potential here, too. At least 50% of these gastrinomas are malignant.
Oh, wow.
Yeah, they frequently metastasize to regional lymph nodes and the liver.
And the systemic web goes even one layer deeper, right? Tying into multiple endocrine neoplasia type 1 or MEN1.
Yes. A quarter of patients with Zollinger-Ellison actually have MNN1, which links this whole hypersecretory state directly to tumors in the parathyroid and pituitary glands.
So you're looking at a stomach ulcer, but the holistic clinical picture might include like hypercalcemia from a parathyroid adenoma.
Exactly. It's all connected.
It really is. But before we move lower into the GI tract, we need to address a very specific type of ulcer that kind of challenges traditional medical heuristics. Sump ulcers.
Ah, yes. The location debate.
Right, because generational medical teaching often says, well, ulcers on the lesser curvature of the stomach are probably benign, while ulcers on the greater curvature should be treated as highly suspicious for malignancy.
And the Mayo Clinic text actively dismantles that geographic reliance.
They really do. They present a classic sump ulcer on the greater curvature that is entirely benign.
Because the critical evaluator isn't location, it is morphology, the physical shape.
So what does a benign sump ulcer actually look like?
A benign one presents with a central crater surrounded by a smooth, symmetric mound of edema, and the crater itself typically projects outward. It doesn't extend inward beyond the normal gastric lumen contour.
So the rule is clear. Location is just an unreliable predictor. You have to analyze the physical architecture of the lesion.
You have to look at the shape, yeah.
And that principle, looking at morphology, becomes so vital when a patient presents with a strictured, narrowed stomach. Because not all strictures are tumors, even if they look basically identical on a scan.
Right, we're talking about the differential diagnosis for a rigid, non-distensible stomach, often referred to as linitis plastica when it's caused by an infiltrating gastric adenocarcinoma.
Where the cancer infiltrates the submucosa and basically turns the stomach into this stiff tube that can't even expand to hold food.
Exactly. But if a severe inflammatory process can do the exact same thing mechanically, how do you differentiate an infiltrative cancer from, say, a granulomatous disease on a scan?
Yeah, how do you, if the stomach looks the same?
Well, often you actually cannot rely on the gastric imaging alone. You have to look for the systemic fingerprints of those mimickers.
Like Crohn's disease, right?
Right. Crohn's is the most common cause of granulomatous gastritis. If Crohn's is scarring the stomach into a rigid tube, that patient will almost universally have visible active disease further down.
Like in the terminal ileum or the colon.
Exactly. The clue is lower down.
And what if the granulomatous cause is sarcoidosis?
Then the discriminator is extraintestinal. A patient with gastric sarcoidosis severe enough to cause a stricture nearly always has disseminated disease elsewhere, like hilar lymphadenopathy in the lungs. The context provides the diagnosis.
Okay, so you have to zoom out. But the text also categorizes two idiopathic mimickers that are really interesting: eosinophilic gastroenteritis and meningerie disease. And with these, spatial awareness within the organ itself is your major clue.
Right, geography inside the stomach. Eosinophilic gastroenteritis is characterized by this dense eosinophilic infiltration of the mucosa and submucosa. And radiographically, it heavily targets the gastric antrum.
So the lower portion of the stomach.
Yeah, and it also involves the small bowel, producing this diffuse or segmental nodular fold thickening.
So if you see a lower stomach stricture combined with small bowel nodularity, that points heavily toward an eosinophilic infiltrate.
Spot on.
Okay, but earlier I was looking at a scan of a stomach with these massive swollen folds at the top up in the fundus. If geography is our main clue, what disease targets the top of the stomach but spares the bottom?
That is the classic presentation of Menetrier disease. It drives massive hypertrophy of the mucosal folds, but it preferentially involves the proximal stomach, so the fundus and the body, while typically sparing the antrum entirely.
It's just so elegant how these patterns emerge when you know what to look for.
Yeah.
So following the digestive tract down from those infiltrative mimickers, we arrive at the massive inflammatory battlegrounds of the colon.
The lower GI tract is a whole different beast.
It really is. The text contrasts two absolute heavyweights here: ulcerative colitis and Crohn's colitis. Let's start with the radiographic hallmarks of ulcerative colitis, or UC.
Well, with UC, the colon loses its normal hostra, those normal segmented pouches.
Right, becomes completely featureless. People often call it the lead pipe appearance.
Exactly, a lead pipe. And the mucosa also has this diffuse granular appearance on imaging, which basically represents superficial mucosal ulceration. The immune system is essentially just stripping away the inner lining of the colon.
And that destructive phase leads to pseudopolyps, which is a tricky term because despite the name, they aren't actually new growths.
No, they're not, because the surrounding mucosa has been ulcerated and scoured away. The remaining islands of surviving normal colonic tissue project upward.
So they just look like polyps relative to the destruction around them.
Right, they're the survivors. And the authors are very careful to distinguish pseudopolyps from inflammatory polyps.
What's the difference?
Well, inflammatory polyps are actual focal regions of inflamed, swollen mucosa. You typically see those in less aggressive, acute phases. Pseudopolyps, by contrast, indicate severe, destructive chronicity.
So pseudopolyps mean the disease has been burning for a long time.
Uh-huh.
But since both UC and Crohn's cause severe inflammation, and Crohn's can also affect the colon, what is our radiographic discriminator there?
The fundamental difference really lies in the depth of the inflammation. Ulcerative colitis is largely a superficial mucosal disease.
It stays on the surface.
Right. But Crohn's disease is transmural. The inflammation literally burns through the entire thickness of the bowel wall.
Which completely explains the complications. Because Crohn's goes all the way through the wall. It causes fistulas, right?
Yes.
Those abnormal tunneling connections where the bowel literally bores a hole into adjacent organs or even the skin.
It's brutal. And that transmural inflammation also causes perianal abscesses and this phenomenon called creeping fat.
Okay, take that.
Yeah, where the inflamed mesenteric fat physically wraps itself around the exterior of the diseased bowel. If you see those complications, fistulas, abscesses, creeping fat, you are dealing with Crohn's.
And the text notes that magnetic resonance imaging, MRI, is actually the preferred modality here.
Oh, absolutely. MRI provides far superior soft tissue contrast for mapping out those complex perianal fistulas compared to a standard CT.
Good to know. Now, while autoimmune diseases dominate the inflammatory differential, there's a distinct colonic emergency that is driven entirely by plumbing and pressure: ischemic colitis.
Which really shifts our demographic. We're now looking at older patients with generalized cardiovascular disease or acute low perfusion states.
Like patients in congestive heart failure or shock.
Exactly. Because the colon has these very specific watershed areas.
Right, border zones where the distal branches of two major arterial supplies meet up.
And the splenic flexure is a classic watershed area. If a patient's global blood pressure drops, these end-of-the-line zones are the very first to starve of oxygen.
The plumbing just can't get the flow there. So on a CT scan, you'll see a circumferentially thickened colonic wall localized specifically to that splenic flexure. But the really scary indicators of advanced ischemia are pneumatosis and portal venous gas.
Right. Pneumatosis being air-trapped within the dying bowel wall as it literally loses its structural integrity.
And portal venous gas.
That means that air is actively being swept into the venous system, draining back to the liver. It signifies transmural bowel infarction and carries, frankly, an exceptionally high mortality rate.
It's a dire situation. And that idea of structural integrity failing kind of brings us to our final section: mechanical obstructions. What happens when the physical pipes twist or, block entirely?
Mechanical failures.
Right. And one of the most complex ones detailed in the text is gallstone ileus. Because a patient presents with a mechanical small bowel obstruction, but the X-ray also shows gas up in the biliary tree, the ducts in the liver.
Which is a huge red flag because those two systems shouldn't be exchanging air.
Exactly. So how does that happen?
The mechanics of it are actually wild.
Yeah.
It begins with severe chronic inflammation of the gallbladder. The inflamed gallbladder physically adheres to the adjacent duodenum.
It gets stuck.
Yeah, and over time, a large gallstone literally erodes directly through those adhered walls, creating a cholecystenteric fistula.
Wow. And that abnormal connection allows intestinal gas to travel backward up into the biliary tree.
Meanwhile, the gallstone drops into the small intestine and acts like a boulder moving through a pipe. It travels distally until it reaches the narrowest point of the small bowel.
Which is usually the ileocecal valve.
Right. It impacts there and creates a complete mechanical obstruction.
That is just an incredible sequence of events. From stones blocking the pipe, we move to the pipe literally twisting on itself. A volvulus.
Where the bowel twists on its own mesentery, strangling its blood supply and blocking transit.
And the two common locations for this are the sigmoid colon and the cecum. So how do we differentiate them on a scan?
It requires recognizing the shape and anatomical trajectory of the dilated bowel segment. A sigmoid volvulus typically appears as this massive, inverted U-shaped loop.
Ascending from the pelvis into the upper abdomen, right?
Yes, often with a tapering beak shape pointing down toward the exact point of torsion.
Kind of like a coffee bean shape. But the thecum, on the other hand, is the origin of the large intestine on the right side. When that twists, it usually flips upward and across the abdomen.
Therefore, a sickle volvulus presents as a massively dilated cecum displaced into the left upper quadrant, while the distal colon remains entirely decompressed.
Okay, that makes sense. But not all obstructions involve a physical knot or a stone. Sometimes the motor itself just stops, resulting in an adynamic ileus.
Right. The bowel just loses its peristaltic function. We often see this post-operatively or in patients on heavy narcotic medications.
And radiographically, an adynamic ileus shows a continuous column of dilated gas and fluid extending all the way down to the rectum, lacking any discrete transition point.
But there is a massive diagnostic pitfall here, tied directly to gravity.
Right, this is such a good pearl.
If a patient is lying flat on their back for a single supine radiograph, the fluid pools in the rectosigmoid colon. Because it is anatomically dependent, it's physically closer to the table.
So the fluid pools and the gas floats upward into the transverse colon.
Exactly. So on the image, the rectum looks totally devoid of gas, which beautifully mimics a physical distal obstruction.
It's a dangerous illusion. It could lead to completely unnecessary surgical interventions. So the clinical fix is just to acquire a decubitus or prone radiograph.
Yes. By changing the patient's relationship to gravity, the gas naturally rises into the rectosigmoid, demonstrating that the pathway is actually patent, and that confirms the diagnosis of an adynamic ileus.
It is incredible how basic physics dictates the diagnosis. and imaging technology has evolved to capture that physics in motion. The text covers the MRI proctogram, which moves beyond static snapshots to evaluate defecation disorders dynamically.
Because anatomy can look completely normal at rest. The MRI proctogram images the patient in real time while they are actively straining.
Oh, so you can physically observe things falling out of place.
Exactly. It allows us to observe abnormal pelvic floor descent or anterior mucosal prolapse that a static CT scan would entirely miss.
Dynamic imaging also reveals hidden vascular dynamics, which is super cool. There's an ultrasound case in the book showing what looks like cystic thickening of the gallbladder wall, just multiple fluid-filled spaces that you might mistake for severe inflammation. But when you apply color Doppler,
Those spaces just light up with vascular flow.
because they aren't cysts at all.
No, they are gallbladder varices,
Yeah.
dilated collateral veins.
And the underlying cause of those varices is blood backing up due to portal venous hypertension, commonly secondary to liver cirrhosis,
So you are looking at the gallbladder, but you are diagnosing a failing liver.
which brings us perfectly full circle to the core philosophy of this text. We are not just identifying isolated shapes. We are interpreting a deeply interconnected physiological system.
It's an ecosystem.
It really is. So to reinforce that philosophy and everything you've learned today, we have a quick clinical vignette for you, the listener, to solve. You are looking at a contrast-enhanced CT of an elderly patient presenting with acute abdominal pain. You identify a circumferentially thickened colonic wall, localized specifically around the splenic flexure, and you spot portal venous gas tracking up toward the liver. What is the most likely diagnosis, and what is the underlying physiological mechanism?
Okay, based on the anatomical watershed location and that ominous presence of venous gas, the diagnosis is ischemic colitis. And the mechanism is a low perfusion state or vascular occlusion that is actively starving that vulnerable terminal arterial zone of oxygen, leading to transmural infarction.
Beautifully explained. We really hope this deep dive has sharpened your clinical eye, demonstrating just the profound amount of data hidden within the shadows of a scan.
And I will leave you with a final thought to consider. We began by comparing radiology to interpreting Kandinsky's abstract art. It requires a holistic, deeply trained human mind to see the systemic connections, like linking a thickened stomach fold to a parathyroid adenoma.
Right.
But as artificial intelligence becomes exponentially better at rapid pattern recognition, will AI eventually see the art faster and more accurately than we do? Or will those subtle systemic clues always require the holistic intuition and physiological reasoning of a human physician?
Something really interesting to mull over before your next clinical rotation. Keep questioning the anatomy, and we will catch you on the next deep dive.